Okay, so my opinion about echocardiography and hemodynamic monitoring in the ICU is that it's actually an extremely useful technique. The questions that arise really, firstly, is echo an optimal monitor? And it's not an ideal monitor because you have to use it intermittently, and the data that you get from it really depends on the operator and the operator interpretation. The real benefit from echocardiography is it tells you not just what's wrong in terms of the hemodynamics, but what to do to put it right. In terms of the duration of the study, really it depends on what you're trying to find out. So for example, if you just want to find out what the pulmonary artery systolic pressure is, you can do that relatively easily from your tricuspid regurgitation, but you must always do it in the context of the whole echocardiogram. So yes, it's useful. No, it's not a perfect monitor, but when you have specific questions to answer and you have knowledge of what the heart normally looks like for that patient, and you can put it into the context of the patient, it's a very useful monitor, and it shouldn't take you too long to do the study. So lung ultrasound is an emerging technique that's being used really in parallel with echocardiography, increasingly in the emergency and the acute setting, and it's being more discovered now by intensivists. It was first developed by Daniel Lichtenstein, and now there are multiple studies going on across the globe by groups in Italy, for example, led by Giovanni Volpicelli, and the Italian and the American group with Vicky Noble, looking at its utility in various bits of various areas of medicine. The main areas where it's useful to us, really, I would suspect, would be related to pneumothorax, the rule in, rule out of pneumothorax, where it is superior to chest radiography and possibly equivalent to CT scanning, and also the demonstration of homogeneous B-line pattern, which is consistent with the diagnosis of interstitial edema. Now, it doesn't tell you what the cause of interstitial edema is, but it tells you about the presence of interstitial edema. And again, it is superior to plain chest radiography in determining whether it's present and possibly equivalent to CT scanning. There are emerging studies that will be coming out from Italy soon that compare estimations using echocardiography of left atrial pressure with the presence of this homogeneous B-line pattern, and that should inform us better as to how we can use it to guide our diagnosis and therapy of patients, in particular with acute heart failure. Okay, so regarding echocardiography and cardiac arrest, there are two areas where it's useful. The first would really be relating to the use of focused cardiac ultrasound. When one is in the non-shockable part of the algorithm and you're looking for something treatable in cardiac arrest, during the 10-second pulse or rhythm check, it has been recommended in guidelines that you can consider using echocardiography or focused cardiac ultrasound to diagnose or exclude some of the potentially treatable causes. These include tamponade, hypovolemia, pulmonary embolism, and left ventricular dysfunction, myocardial infarction. Aside from that, echocardiography as a comprehensive study is extremely useful in guiding post-resuscitation care of the heart, diagnosing again the underlying cause and being used in its extended role in critical care to optimize patient management. So in short, yes, during cardiac arrest, provided you have an optimally trained practitioner and you don't interrupt chest compressions, and then after successful resuscitation of the patient to guide ongoing diagnosis and therapy.